guys, welcome back to Medical Coding with Blue. Today's episode is all about what is inpatient coding, outpatient coding, pro-fee coding, and risk adjustment coding. If you're brand new to my channel, welcome. I am Blue, I'm a medical coder. Okay guys, so I know that looking at some of these job listings, the vernacular can get a little confusing, especially to somebody who's brand new. And I understand. Okay, so let me break down what all of these different types of coding are, right? And then let me explain something first, because sometimes people will say that's inpatient coding when they are referring to pro-fee, okay? But that's somebody that's been in the industry, that knows the audience that they're talking to and that kind of thing. But let me explain something first. In healthcare, to be paid, there is the physician that needs to be paid and there is the facility that needs to get paid. Right? So let's just, that's the description of this first. When the physician is getting paid, they are getting paid for their cognitive work. So all of the decision making they have to do, all of the procedures that they are doing, this is all outpatient coding, right? And so in this, we have to have a book to cover all of these procedures. And this book is saying that this is for physician coding. And that is going to be your CPT manual, your current procedural terminology manual, okay? That's the book that has all of the outpatient procedures in it, okay? Sometimes providers are doing these procedures. Sometimes it's the technicians that are doing these procedures. And it all depends, okay? And sometimes it's nurses, right? Because we have the E&M code that nurses can get in there as well. So that's something that you have to know. In the CPT manual, it's covering your procedures, your modifiers, and your evaluation and management levels, okay? So there's a lot that's in the CPT manual, but just so you know that when we are thinking of physicians or we're thinking of the technicians and how the physicians are getting paid, it's in the CPT manual. That's the most basic way that I can explain it. There's a lot more to it, but that's just so you know. When we look at the CPT manual, we're thinking of the provider and outpatient, okay? Now, then there's the inpatient side. So for the hospitals to get paid, or for the facilities to get paid for their equipment, for the use of their staff, for all of the supplies and everything like that, we have to have a separate code set for that, okay? Not all people know the ICD-10 PCS manual coding, okay? So that's the thing that you have to know there. That's covered. All of the procedures that are done in a facility are covered in ICD-10 PCS, okay? So there is no evaluation and management when it comes to the inpatient in the ICD-10 PCS book. Why? Because this is supposed to cover for all of the procedures that are happening in-house in a facility. That is ICD-10 PCS. And oftentimes when people are referring to inpatient coding, they are referring to it this way. I will explain pro-fee here in a minute because that's also referred to as inpatient. But let me finish explaining the PCS part first. So again, in the PCS book, we are covering all of the procedures that are done in-house. This covers everything that is done in-house. So when a patient is staying in a hospital, all of the procedures that are done in that hospital are covered with those procedures that are in the ICD-10 PCS manual. Not all coders will know about ICD-10 PCS, okay? Because for the most part, when you're learning coding, a lot of programs are teaching you outpatient because they feel that that's the easiest to learn first. And technically it is easier to learn, although there are some programs that teach both inpatient coding and outpatient coding, and they do teach ICD-10 CM, which is our diagnosis coding. Everybody uses that. They teach CPT and they teach ICD-10 PCS. So this allows the student to have their choice on whatever it is that they want to do, whichever credential they want to sit for. So with that said, and of course, like a broken record, there are 4 credentials that employers are looking for. You only need one for the first 2 years if you're a medical coder, okay? The gold standard of medical coding credentials is the CCS. That is because that is the mastery medical coding certification. There is no more mastery than in medical coding that you could get than the CCS. Okay. Then there's a CCA, which is a Certified Coding Associate. Fantastic credential. I had it for 13 years. This says you have the entry level knowledge of inpatient coding and outpatient coding. And then there's a CCSP, the Certified Coding Specialist, physician based. Now this credential says that you know all of there is to know about the outpatient setting. And of course, outpatient is going to cover everything in that CPT manual. Okay, all those procedures, the modifiers, and evaluation and management. Okay, and plus all the other things like reimbursement and the laws and things like that. So that's all covered on that exam. Then there's the CPC, or the Certified Professional Coder exam. This credential is the one with AAPC, the American Academy of Professional Coders. That's their flagship credential, and that says that you have that knowledge of outpatient coding. Okay, so again, those folks can use the CPT manual. Okay, they know all about that. All right. So now that we have that clear, that there's two categories of person and entity that need to get paid. Okay, so that's the thing that you got to know there first. So when we say outpatient, we are referring to that CPT manual, and of course we will use the ICD-10-CM because that is our diagnosis codes. And in the outpatient setting, you will also use the HCPCS Level 2. Now, HCPCS Level 2, that's going to cover all of your durable medical equipment, all of those procedures that are not covered in CPT. One that comes to mind very quickly is for Medicare. They have their colonoscopy codes in the HCPCS manual. So that's where you will find those. Mileage is also covered in there if mileage is a part of the thing that you have to pick up. The HCPCS codes are also very insurance specific. So sometimes there are some certain insurance companies that are going to require the use of some of those codes. So you have to make sure that you understand that, if you're in the billing process. If you're not, you still need to ask the billers, okay? So that way everything can be clear and you're reporting the correct code, so that way that there's no pushback when they go to submit the claim, okay? So, but they use all of these 3 books in the outpatient setting. Now, in the inpatient setting, you're going to still use the ICD-10-CM book because, of course, that's our diagnosis. ICD-10-PCS, of course, that's our procedures, okay? And there's no modifiers in PCS, just so everybody understands, because everything is covered in those codes. And then there's the HCPCS Level 2 book. That's also covered and used on the inpatient side. Now, why do they use it? They use it for like the bandages and durable medical equipment and things like that. So HCPCS is the one that can be reported on either side. Same thing with ICD-10-CM. Now, there are differences in how the ICD-10-CM codes are reported, and we'll get to that here in a second, okay? So we're following along, right? Okay, so now let me explain outpatient. What is outpatient coding? Outpatient coding is for the provider to get paid, right? So if there's outpatient clinics in a hospital, which I work at a hospital, but I work in the outpatient side. I work in the outpatient clinic, because you can go to your hospital and then show up to whatever clinic you're supposed to report to, whether it's ortho, podiatry, or cardiology, any of those. And then the procedures and everything that happens in that clinic, or the evaluation and management service that happens in that clinic, all covered in that outpatient coding. And that's going to be ICD-10-CM, CPT, and HCPCS. Now, I do minor procedures and major procedures in my clinic. I work for the orthopedic and podiatry clinics. I am their sole coder. Nobody touches their encounters but me. And I like it that way. I like it that way because my providers are mine. That is my clinic, and I'm the one who codes it. I am responsible. Okay. So with that said, in the clinics, it depends. Some clinics do not report major procedures. Major procedures that are reported in my clinic, because I'm in orthopedics and podiatry, if there is a closed treatment of a fracture, right? It's, say, for instance, they're putting a cast on a patient. The patient comes in, they have a fracture because they looked at it under x-ray. Oh, there's a fracture. That fracture treatment code is going to be found in that CPT manual that I'm going to report. And if it's the first time, this is the initial treatment for it, I'm going to report that procedure code for that. And when I do, that's going to put that patient into a major global period, because there's 90 days global period for those major procedures. Even though my patient did not have to go up to the OR, that procedure was performed right in the clinic. It depends on that code, how many global days are in that code. Now, again, not all people will report codes like this. It really all depends on your clinic. And I will talk about that in another video, like how do you figure this stuff out? But I will talk about that then. One thing at a time. I'm just trying to explain these parts first. So sometimes I report minor procedures. Minor procedures are procedures that have a 0 to 10 day global period on them. And that means that the evaluation and management's already decided in those procedures to perform those. So there's different rules to those, okay? But I report those. I also report evaluation and management coding in my clinic. So if it's applicable, if this evaluation and management code is applicable to this visit, then I report that for the provider. So that's what you do in the outpatient setting, all right? Now I've done a couple of videos talking about what I do in a day, or what do outpatient coders do. Now I explain things. I will never, ever, ever on my channel, I will never, ever show you what it looks like to code a chart. Never. Because these records are private. I will never, ever do that. I don't ever want to get any kind of potential HIPAA violation ever. And I will not do the blur out, because people that are smarter than me can figure out how to unblur. No, I don't think so. I don't think so. So I will continue to explain what I do. And people have gotten upset with me. I don't care. I'm telling y'all so that y'all are prepared. Every place is different, and not every place uses the same electronic health record system. Just gonna leave that one there. Now, the inpatient side. So the inpatient coders are the ones that are going to be capturing the charges for the facility. So they still need to report the diagnosis codes that are for these procedures, right? Because if a person is coming in-house and staying in-house, the facility's got to get paid. They've got to be able to cover for all of the bandages and all the durable medical equipment and all the use of their staff, like the nurses and things like that. So that's something that is, all those procedures, it's all covered when they're reporting those. So what the inpatient coders will do is they will report the diagnosis codes, and they will report any applicable ICD-10 PCS codes. So with that said, the inpatient coders do not report evaluation and management. Okay, they only report the facility coding, which is the ICD-10 PCS. So that's what they do. And they have different rules as far as what they can pick up, because sometimes you can only report what's definitive in the outpatient setting, and on the inpatient side, we are reporting for what they're treating them for, because sometimes they don't know what the patient has when they're coming in. So sometimes they're just treating them for this condition, and until they confirm it, that's what's being picked up, okay? I don't want to get into a whole discussion about all that, because I tried to keep these as clear as possible, but that's just what I want you guys to know about that inpatient coding. So if you are coding for that inpatient side, not to say that CPC coders can't code on the inpatient side, because all of the coders at my facility, they all have their CPC. They learned on the job. Sometimes that's possible, but it really all depends on the place. But for us here at my facility, that's what we do. And they have learned on the job. They still have their CPCs, okay? If you want to work on that inpatient side, if you want to work for the facility and you don't want to have to code for evaluation and management and modifiers and all that kind of thing, you want to make sure that you arm yourself with the right credential. The right credential being the CCA or the CCS, because this says that you know inpatient coding and outpatient coding, okay? These are the credentials that employers are looking for. And on that inpatient side, we'll say this also, it's very important that you understand the importance of sequencing, because how the procedures are sequenced is how the patient falls into a DRG, or diagnosis related group. and that is going to determine how many days this patient is on average going to stay in that facility. And that's what they're going to be basing those payments off of, is what their diagnosis related group is. So make sure that you really understand that. Inpatient coders also have to really understand pathophysiology. I've seen a lot of mistakes from people like asking me questions, and I'm like, you don't know pathophysiology, do you? Because that's something that you got to be really strong on that inpatient side, okay? And you got to be really strong with anatomy too, because anatomy is strong on both sides, but never more so clear with all of the detail that comes into those ICD-10 PCS procedure codes. Because it's a seven characters, and if you screw up one of those because you don't know your anatomy well, that's going to screw up the whole code, and the whole code is wrong. You do not get partial credit on the outside for getting part of the code wrong, and just because you got one letter wrong, oh, will they give me credit for the rest of it? Heck no. You got one letter wrong, the whole thing is wrong, okay? And again, I don't want y'all to be scared. I want y'all to be prepared. I mean, that's the thing. I wouldn't want somebody to just give me the fluffy version. I want somebody to tell me, okay, what can I expect? Okay, now I just told somebody, hey, make sure that you know pathophysiology. I hope somebody hears me and says, oh, I'm going to buckle down on pathophysiology so I can really understand and be prepared. Yes, you do have to be prepared, okay? Because, again, you have to have that sequencing correct, and you have to have all of those characters correct, and all of that's going to require that strong anatomy knowledge and that strong pathophysiology knowledge, okay? And there's a lot more, but I could get into it on another video, or y'all can go back and check out my specific videos about what different specialties do, okay? So that's explained on that one, so hopefully y'all get that. Now, inpatient coding, again, that's for the facility to get paid. There's no modifiers, no E&M, but it does require you to have a strong understanding of that pathophysiology, a strong understanding of anatomy, okay? Because those ICD-10 PCS procedures are not playing around, okay? Just saying. Now, for pro-fee coding, okay? Now we're going back to the outpatient side. But here's the thing. The patient is not just walking in the clinic. The patient is staying in-house. So when we say pro-fee coding, this is just the best way for me to explain it. Some places may do things a little bit different, but I'm just trying to give you a visual of what pro-fee means. Okay, so in this example, this is what I'm talking about. The patient staying in-house, and they are admitted by the internal medicine team. Internal medicine looks the patient over. This is a diabetic patient, and the internal medicine team sees that the patient has a foot ulcer. Okay, so internal medicine, they're going to say, okay, you know what? We need to bring in, the specialty team. Let's call up podiatry. Hey, podiatry, we have a patient up here who's a diabetic, and I just spotted a foot ulcer. Can you come up and check them out? Podiatrist says, sure, I'll be on my way up there. Now, in order for this podiatrist to get paid for going up to the floor and checking out this patient, that's when the pro-fee coding comes into play. So you will see in the CPT manual that there's the inpatient evaluation and management services, okay? So that's where it starts with 99221, 222, 223. So you will look at those. They have the subsequent days. The patient is in there. They come in and they do their rounds, 99231, 232, I'm trying to remember it off the top of my head, but you can look in there and you'll see those subsequent day visits. And then you will also see the E&M for the discharge date of service, 99238 and 99239, if I remember correctly. But so they will, based on where the patient is like the initial is when the provider, the podiatrist goes up and sees the patient. And then when they go in and they check on them, the next day, and they're going to have that subsequent encounter. And then they're going to have the discharge day whenever they discharge the patient, okay? So that's recording the work of that physician that is going up to the floor to go take care of that patient, okay? Now the rules, as far as like what's being picked up, they're going to follow that outpatient setting. So we are going to pick up what is definitive. What do we know for sure? Okay. So that's what we're going to pick up while we're up there in the floor doing those things. If there's any procedures, again, same thing. We're reporting those with that CPT code to collect that payment for that provider. Okay. So that's pro fee, professional fee coding. PRO space FEE. Now I spell this because somebody was really confused the last time I did a video about pro fee. They were asking, and it was suddenly a huge debate about what I was saying. I thought I was very clear. Pro fee, professional fee. So that's so you know that part. Now a lot of people get scared of this. I don't know why. That was when I went to the second facility that I worked for. That was what I was coding for. And that experience was what got me my position here at my forever home, because they were so excited that I was somebody who actually understood how to do inpatient coding. And once you get it, you get it. Like the patient will come in, and of course you're picking up the applicable codes. And then when they are on their subsequent days, you're going to see their condition is going to change, hopefully for the better, but you're going to still carry a lot of those same diagnoses. Some you may have to change. Some you may have to, okay, if it's resolved and things like that, then obviously we're not reporting resolved. So that's, again, going back to that outpatient way of thinking, okay? So take a look at your CPT manual and you can see all of those pro fee codes. When we talk about inpatient, okay, subsequent day and discharge day, you will see those in the CPT manual. So again, to me, as somebody who does that, you got to see all of the different specialties. I reported for every single specialty in that hospital because I was a pro fee coder. And it was a lot of fun. I mean, you know, and we got a lot of overtime to take care of a lot of that stuff too, because again, they couldn't keep somebody to do pro fee because it was so confusing for the people. And they were just like, they didn't want to have to deal with it. And I wasn't in a position to be choosy either. This was a no-fail situation. And it's the same thing that you got to look at it when you get into these types of positions too, is that you can't fail. Because the second you try to like retreat back into, oh no, I'm confused and I'm scared and it just doesn't make sense and the person doesn't want to answer my questions, then you need to learn to do your research, right? You need to learn to do your research. And trust me, there's a lot more resources out there from the time that I started, right? Because that was in 2008 that I was doing that. 2008, 2009, I started with Profi. So again, back then there wasn't that many resources. Now you see resources all over the place, you know, to help you to understand. And let your fingers do the walking, guys. That's the thing you got to do, okay? Now, before I run out of time, because I discussed what Profi is, now let's get into that risk adjustment coding. So risk adjustment, and now you will hear me say when I talk about like jobs to start, alternative jobs to start, risk adjustment is one of the ones that I say this is a good place to start, but not a good place to stay. Now, if you get offended, again, nothing that I can do. I can't do anything about people getting offended, because if you truly understand what I'm saying, you'll know I'm not insulting you. This is not personal. This is so that people understand, because I'm the one who gets emails. When you get emails from people with heartbreaking stories, then come talk to me. But until you do, listen to what I have to say. People have been in, they get so excited they get into risk adjustment coding, and that's where they end up staying. Some people have told me, Bleu, I've been in risk adjustment for 4 years, and now I'm really bored. And I got really bored starting when I was 6 months in, but I just couldn't go anywhere because I had finally gotten my job and I was too scared to start again somewhere. Well, guess what happens when you do that? You miss out on a lot, because risk adjustment coding is only diagnosis coding. Risk adjustment coding's purpose is for data capture. It is so that the insurance companies can see, okay, so this person is a diabetic and maybe they have all of these other conditions, and they start seeing a pattern. They start putting it through an algorithm, and this algorithm starts matching up that patients who have diabetes potentially also have issues with their cholesterol, potentially also have these other issues. So then they start doing that. Now they start using this information to figure out how much is it going to cost to take care of this patient, to continue to take care of this patient. And as the aging population gets older and older, there's more and more people on these government programs. Medicare was the first one to start it, okay? Everybody follows after Medicare. Now there's other insurances, commercial insurances, that saw the value and risk adjustment. And they say, okay, well, we're capturing all this data, and now we can use this data to our advantage, because now we can plan. We can plan how to use our resources and funds, and maybe we can use this data to make like educational programs to help people to understand this is what happens when you're not exercising, or when you are in this age group and you should be increasing this activity or that activity, or decreasing this food or that food. You know what I mean? Like, there's a lot of things that can come from the data that's pulled from risk adjustment coding. But basically what you're doing with risk adjustment coding is you're looking at the document and you're pulling out those diagnosis codes. It's just diagnosis coding. There's no procedure coding, no evaluation and management capture, no modifiers, no nothing. You are only using that ICD-10-CM book. The thing that I tell you guys to make it a short stay is because people will say, oh, well, I can start in risk adjustment, get my year of experience, and then I can apply elsewhere. Well, guess what? I've seen job listings that have said if your only experience has been risk adjustment, this doesn't count as experience. Risk adjustment is only diagnosis coding. That means that your procedure coding, your evaluation and management leveling, all of that is starting to atrophy. Because there's a very small percentage of you that will still continue to study. Very small. So, but if you are starting and you say, well, I'm going to be here 3 months or 6 months doing this, guess what happens then? That's good enough time for you to still continue to practice with the CPT coding on your own. But what you're going to do with this time is you're going to learn about the electronic health record. You're going to learn about what it looks like in the real world to look at an actual record. And you're going to learn about code abstraction. Now, code abstraction means that there are no codes selected, right? Potentially. There may be codes already selected, but if there isn't and it needs to be picked up, you're the one who's picking up that code. That's code abstraction. If it's not picked up and you're picking it up, that's code abstraction. There's also procedure abstraction as well. But that means that you're selecting it based on that documentation, if that documentation is supporting. So that's what you're doing there. That's building a skill. That's something that you can put onto your resume, and now we have some experience. And again, if you stay for a short amount of time, that's going to look really good, because you're still going to be able to be like, okay, I can still practice on my CPT coding and I won't lose that skill. People will lose their skill. You will. It's just like people who say, well, I'll pay off this bill in a short amount of time, and then they end up making the minimum payments, and then you end up spending 7 years or so trying to, pay off this bill. Again, a very small percentage of people will actually do what they say that they're going to do, which is to do the practice, to learn the CPT side or retain their skills. So anyway, but that's something that you have to think about when you are getting into this industry. Now, again, risk adjustment is a great place to start, but not a great place to stay. It's a good place to get your foot in the door and get that feeling of production, right? What is productivity like? Can I meet this productivity? Getting acquainted with those electronic health records, because that's something that you could put onto your resume. And again, it looks great on your resume that you have this experience now. But again, a lot of people will get hung up on, well, I don't want to start a job and then, leave right away, or it's going to show so short a time. Everybody knows in this industry that that's what happens in the beginning, that sometimes finding your forever home takes a few tries. It took me my first job, which was through a temp agency, my second job through the temp agency again, and then I finally got my, on the third try is when I got my forever home job. So again, don't worry about, oh, I was only here for 3 months or 6 months and it's going to look really bad. No, it's not. They're going to know that you're starting off, you're trying to get your experience. This was the first place that was willing to hire you, and now you are out there and you want to work for them. Okay, because back in the day, back in the day, like 2018, 2019, they weren't asking for anybody to be certified to do risk adjustment coding because they were just doing data collection. Now that the popularity of the CRC, which is not needed, because even though they say, oh, it's preferred, well, guess what? They also say that if you have the CCS, CCA, or the CCSP, or the CPC, that they'll take that as well. Why? Because diagnosis coding is already covered on those exams. So again, it's just why people ask for it, I don't know. And again, not everybody that's in leadership understands what these credentials mean, and they're just listening to other people. Okay? So that's why I say, if you want to get it, but you don't need it, okay? And especially for my first year people, all right? My first year people, y'all really need to have one credential and concentrate on it, work on getting your CEUs, work on getting your footing and your firm understanding of what's happening, and then move on and get more credentials if you want to. That has nothing to do with the credential that you currently have, okay? That's what it's all about, is variety. Because when I see stuff doubling up, there's no need for it, guys. That's just my advice anyway. So with that said, I'm going to go ahead and wrap this one up. But hopefully this has helped you. Thank you guys so much for joining me. If this video helped you, please like, subscribe, and share. And I'll see you next time. Bye.